So welcome to NMPGU OMNSD DCU research webinars with DCU and OMNSD up in the North. Welcome again. It's our fourth one today, and today Anne Matthews is going to do systematic reviews. So Anne, I'll hand over to you. We're going to break about 2:45, about a 15-minute break, and we'll carry on until about 3:30. Okay. Enjoy, everybody, and thank you, Anne and Kate. Thank you.
Thank you very much, and hopefully you can hear me. You can let me know if you can't. It's lovely to be here. Just to let people know, we are recording this, so hopefully you're supposed to be here at this stage. And I'm delighted to join you today. I haven't been part of the webinar series before, but hopefully some of you might have we might have met in DCU or elsewhere. So I'll keep a close eye on my time. Could keep talking, so I better not for the rest of the day, but I will just keep going for, maybe Kate said, about 40 minutes, and then we'll break and then be much more interactive after that. So while this session is about systematic reviews, I just want to put it in a wider kind of context of evidence synthesis, and I'll explain all of that. And as Kate and Lorraine said, I'm at the School of Nursing, Psychotherapy and Community Health at Dublin City University, and I've been there for 20 years, so that's quite a sentence. Of every day of it has been enjoyable. I'd love to maybe, hear more about all of you and where you're working, what you're interested in. But I suppose we won't go through introductions of you to me at this stage, but we can definitely come back to that after the break. And I really just want to emphasize, the number of review types, the kind of diversification of all of that. But I will be focusing on systematic reviews, and just to kind of highlight from the word go that I've mostly been involved in Cochrane systematic reviews. All of that will become clear, and here are some really important, in my world, websites. Cochrane, the Cochrane Collaboration, the Cochrane Library you've probably come across, and the Cochrane kind of systematic reviewing handbook. So that used to be a big book, and a few people in the world had it, but now it's online. Each section gets updated, and it really is a really cherished resource for everybody doing systematic reviews, whether they're involved in Cochrane or not. Just to say, I will probably keep going, but if you have any questions, do hang on to them, and I can follow them up or put them in the chat, or we'll aim to be as interactive as we can later on. So just again to highlight, most of my own experience is Cochrane systematic reviewing, so SRs of randomized controlled trials, or CTs, because of the specific questions that we needed to answer. So that's not to say there are only systematic reviews of randomized controlled trials. So there are systematic reviews of non-randomized studies, and there are lots of other types of reviews of all different kinds of studies. But if you have a specific question, which is A more effective than B for a particular group with a particular condition, and if your researchers in that field have carried out RCTs, then it makes most sense, and probably more than that, a requirement to do a systematic review of those RCTs. So it really does depend on your question, as always, but also on the evidence that you think you'll be likely to find. So there are really a lot of other questions we know about how people experience care, how people experience illness or other phenomena. There are lots of, as many type of research designs now as you could imagine, and therefore different kind of review types. So a review sounds kind of obvious, but it is a secondary research approach or design. So secondary means that you're not collecting your own primary data. Now, other secondary research designs are things like you might do a chart review. So you have somebody else has information gathered in patients' charts, and you want to come along and relook at that data, which wasn't data in the first place. They were patient clinical information or patient records, and you're now reviewing those with a secondary research hat on. So it's not the only secondary research design, but just important to keep in mind that it is secondary research. So you're actively going back to something that somebody else produced and you're doing something again with it. So it's important to really see it as that, because it's not that you're just kind of saying, oh, I found 5 reports and look, this one said this and the other one said something else. And, you know, so it's really important that you do something the second time with them, that you're creating new understandings, knowledge, answers to research questions the second time. And just another website I probably should have moved up to my front page is Evidence Synthesis Ireland. There used to be an entity called Cochrane Ireland that was independent in Ireland as part of the Cochrane Collaboration. It was closely linked with the UK Cochrane organisation, but since the last maybe 3 years or so, Cochrane Ireland has become subsumed, if you like, under this much bigger entity, Evidence Synthesis Ireland. Now, I really would encourage you to go there. I was just on to Evidence Synthesis Ireland folks this morning. They run now really all the training in Ireland for evidence synthesis. So that includes Cochrane Systematic Reviewing that we're talking a bit more about today, qualitative synthesis. I was at brilliant stuff about scoping reviews with Evidence Synthesis Ireland. And by stuff, sorry, I mean a webinar. So, you know, they're really brilliant. They have webinars, they've training courses. So I'm running with my colleague Veronica in the coming weeks a 4 half-day session on systematic reviewing. So you know, they advertise those kind of courses and run them. So if you really want to take another step, have a look at those. They're really brilliant resources. And I suppose just to make it more complicated then, and I will share these slides, of course, so you can click in these links. You know, the idea years ago, you might have said, well, I'm doing a review, whereas now we talk about typologies of reviews, families of reviews, or review families. So each kind of sets of reviews are grouped into families. So those articles are one is very old, the one about the associated information retrieval requirements, because this was developed, this article, by a group of librarians or information specialists who were getting a lot of requests from people like us saying, I'm doing a review, can you find me all the evidence, can you help me find all the evidence on this? And they would say, oh, what's that kind of review? What does that mean? So, you know, there's great kind of collaboration goes on in this kind of work with information specialists. So this is that, those information specialists. Andrew Booth is somebody you'll come across a lot for various types of review work, but he's an information specialist supporting researchers doing reviews. And they had these 14 review types, and they were saying, you know, here are the kind of information retrieval implications of those. So like at the very bottom here, umbrella review is a review of reviews. Sometimes we or our students might say, I want to do a review of something. And we'd say, oh, look, there are 4 reviews already. But why do they all have different conclusions? What is it about them that makes the conclusions different? So you can do a kind of a review of reviews, or an overview of reviews, or an umbrella review. So I've given you 3 terms there for this same thing: umbrella review, overview of reviews, or review of reviews. So the terminology can be a little bit confusing. In here we have my friend, the systematic review. But I suppose over time I've gotten involved in scoping reviews. We just published one recently, and I'm just undertaking another one about baby-friendly hospital initiative globally. And we have 280 articles included in that scoping review. So it's really quite different than the kind of much narrower question, and therefore kind of more focused evidence that we would find for a systematic review. So I can definitely come back to this if anybody wants, you know, towards the end, but I'll cover some of these to a greater extent as I go through. And then the other authors I mentioned on that link said there are 48 review types, and they're in families, making it sound all very friendly. Traditional reviews, so things like literature reviews in here, critical reviews, systematic review family, the review of review families, the rapid reviews, qualitative reviews, mixed methods family, and purpose specific family, which, like we all use purpose specific, can fit anything else. So, you know, again, just to show you that there is this kind of range of reviews. Now there are families and types of reviews all within that. So I would say to you, therefore, that should be quite comforting or maybe encouraging, that if you have a research question and you feel there is evidence out there about that topic, then you can decide what kind of a review should you be doing. And it is based on the question, but it's also based on kind of, I don't want to say intuitively, but, you know, kind of provisionally what you know is out there in terms of evidence. In other words, if I was interested in, you know, the phenomenon of adjustment to, you know, the loss of a limb, am I going to do a systematic review of RCTs? Like, it just doesn't fit. So I'd be thinking, okay, you know, let me do a kind of a provisional search, see, is there phenomenological research, other qualitative research about this? And then let me see, how will I bring all that research together to kind of move our understanding on, not just saying there are 5 studies, they all found different things. It's really, how will I analyze, reanalyze what they found? Now, having said that, I would say that we're not really supposed to do full kind of rigorous searches before you decide on your review question and parameters, because if you do, it would start to kind of predetermine your question. Suppose I did a search and I found there are, you know, only studies of women experiencing a certain phenomenon, then I'd say, oh, I'm going to do a review on how this affects women. But that mightn't be the right question. It might be, how does it impact on adults? And one important conclusion would be, there are only studies that, you know, show how this affects women. So this kind of idea that you would set up your criteria, your inclusion criteria, your search items, kind of a priori or before you do your kind of systematic searches, because otherwise you're maybe starting to change your criteria, but that, you know, not based on your actual curiosity that began in the first place. Maybe a more kind of small level question there. Myself and Veronica were involved in a Cochrane systematic review of virtual reality for children, you know, going into hospital for procedures and how virtual reality might reduce pain. And, you know, we took children to be up to 18, but some studies included children up to 19. So if we had read the studies first, we might say, oh, let's stretch our criteria to include those studies. So let's say 19. Even though, you know, using international definitions of childhood and childhood ending at 18, we really needed to stick to the 18. So in other words, you'd be trying to kind of shoehorn your question into the evidence that you thought was there, rather than the other way around. Hopefully that's not too confusing. So there is no best review. I would say there is a kind of a perceived hierarchy, that at the top actually would have the overview of reviews. Then you'd have the systematic reviews, then you'd have different kind of levels of reviews. But this recent article from Trish Greenhalgh and others about, you know, maybe the narrative review is what we need in a certain context and to answer a certain question. And these authors were given kind of free rein to write this article, and they wrote it saying, let's kind of move away from those hierarchies. So in the same way as we wouldn't like to say that an RCT is best in all circumstances, than best and better than some other type of research design, we would never say a systematic review of the type I'm going to talk about is better than another type of review, because it just mightn't be appropriate at all. So we just need to keep that in mind as we're going through. And the other, I suppose, element is the one on the left here is our Cochrane review. Very kind of snappy title. Well, maybe that's only my own delusions of interventions for nausea and vomiting in early pregnancy. So, you know, it's a review of interventions, all interventions. You know, Cochrane are really prescriptive as to how you name your reviews. Everything about Cochrane is very prescriptive, I would say, in a really positive way for me as I'm learning them. Whereas myself and Veronica were involved in this I was going to say this beast, but it was a beast of a work, a systematic literature review to support the development of a national clinical guideline on pediatric early warning system. So you can see already that's a less clear scenario. What's a systematic literature review? Now I should say, we're always happy to do this kind of work, especially it was for the Department of Health. It's needed. They needed a clinical guideline, and this is what our review was to inform. But if we just look at the kind of objectives for my Cochrane review, is to assess the effectiveness and safety of all interventions used for nausea, vomiting and retching in early pregnancy up to 20 weeks gestation. So again, the objective now has a lot more detail, sets out the gestational period that will be, you know, trials who have women up to 20 weeks gestation involved. Those trials will be included. It's early pregnancy, therefore, well, early pregnancy would usually have a slightly different definition. That's why it's important to specify the 20 weeks here. All interventions, so that's very broad. Effectiveness, you know, effectiveness of what, on what, so we have to specify more about outcomes and safety. But you can see, even though I've broken it down there, it's still quite a neat objective. Whereas here, these were our objectives for the commissioned review. And so when we apply for a tender, we say we'll do what was asked, or else we won't be asked to do it. But this was a much wider set of objectives. What systems are currently in use, including emergency department, what's the clinical validation, what education programs are there, how have they been evaluated, what kind of economic analysis has been carried out, and then we had to conduct a budget impact analysis, which is a nice learning process for us. But the other thing there was, we included in here that we would write to people, we would organize interviews, we would use grey literature, we would, you know, trawl the world for this kind of information to support this clinical guideline development, which is the right thing to do. We found brilliant PowerPoint presentations. We contacted authors of those. We found hospital level guidelines. So we had to be, you know, that was more like almost a scoping review, whereas this is a really kind of traditional systematic review. So a systematic review, therefore, attempts to collate all empirical evidence that fits pre-specified eligibility criteria in order to answer a specific research question. It uses explicit, systematic methods that are selected to minimize bias of the review process and provide more reliable findings from which conclusions can be drawn. So it never quite says we have found the answer to this, but you're trying to all the time reduce bias, and that kind of definition comes from the handbook. And, you know, you'll hear Archie Cochrane quoted. He was a medical doctor, and he, I suppose, right back in 1979, was saying that, you know, somebody in a clinical setting trying to answer the question, you know, what's the critical summary for this, you know, patient group, the patient who's in front of me, what is the evidence kind of brought together, and that rather than the clinicians and everybody being impacted by the latest thing that landed on their desk, in the old days when journals were more likely to actually land on your desk, but maybe now it's an alert, and, you know, just being really conscious of our own biases towards maybe what's new, what's the biggest sample, what was done by our colleagues, just all these kind of biases in how we interpret evidence. So he asked the global community, and then he set about with the pregnancy and childbirth group first, bringing this kind of critical summary together. So that's what a Cochrane systematic review began as. So again, it's a secondary review of primary research. So somebody else did the research, published it, or maybe didn't publish it. And it becomes more difficult if they don't publish it, but we should try to find unpublished research because of all the publication biases that studies that find kind of in favor of a new treatment are more likely to get published than those who don't. All of those issues, we try to look at those in the systematic reviewing process. So we're really trying to be, you know, very open in our own review process, as we would like people to have been in their trials. But because we're judging people's kind of risk of bias and all of these things in the trials, we also have to be very conscious of our own bias. So overall, Cochrane Collaboration supports this, you know, the ultimate goal is to support evidence-based healthcare decisions by preparing and promoting and maintaining these systematic reviews. So some of this is kind of repeated, very clear question, very precise, reproducible methodology and methods. You'd like to think if somebody came along and had the same studies to synthesize, that they would be able to do that. We really try to find all the studies. So generally in a Cochrane review, you wouldn't limit by language. And, you know, most of our own master's students in DCU and maybe other, could even be PhD students going along or other settings, would say, I'm only going to be able to access the studies that are published in English. But there is, again, in there a kind of a bias. And while English is the predominant, you know, language of medical and clinical studies and where they're published, it does outrule, you know, quite vast amounts of evidence. For example, in our scoping review of the Baby Friendly Hospital Initiative, a lot of studies are from Brazil because of various initiatives. So we have said we'll only include English, so we're not including those that are written in other languages, but we need to be really conscious of that. So in any of my Cochrane reviews, we've taken in all the studies in the other languages, Farsi, range of languages, where we've then tried to get critical pieces of these articles translated for free within that kind of global kind of Cochrane community. And it could be by somebody's colleague or a friend, and we kind of submit that translation into the Cochrane group. They hold it for other people, and people have contacted me for the translations. So again, it's all about being transparent as you go through. We do assess things like risk of bias, and, you know, really try to add something new, and not just here's a whole load of studies I found, have a read yourself. You're saying here's what I'm doing is adding something greater than just these studies separately. I'm building something based on my analysis of these studies. And I suppose two terms that were on our list at the beginning, a systematic review and a meta-analysis. So sometimes these get a little bit confused. They often and probably preferably do overlap. So you would start with a systematic review, which starts with a systematic search and says, okay, let me review these studies and let me look at their, you know, what happened in the study, how the study was conducted. Let me, you know, evaluate the study, and if possible, let me try to pool the results of these studies so that I have kind of one overall estimate of, if all of these studies measured the same kind of intervention for the same group of people, can I pool their data in a meta-analysis? So preferably I'd be in here in the middle where I've done the systematic review and I can do a meta-analysis. I'll show you what that looks like. But the only time you would have a meta-analysis without a systematic review is if I came along and said, I found 4 studies that, you know, have compared the, you know, this kind of heparin with another kind of heparin, and I'm going to meta-analyze them. But you wouldn't know, are there other studies I haven't included? So this is a kind of a natural process to systematically search, review, and then meta-analyze if you can. So that's what I've been saying. A meta-analysis calculates a treatment effect based on pooled data from a group of studies, looking at kind of overall, taking into account each of the studies, size, kind of level of, the level of confidence you'd have in that study. You know, how does this all pool together? It's not a question of adding up all the people in one group, all the people in the other group. It's taking each study by itself and just making sure that they're given, you know, kind of a fair weighting, if you like. I would say, and Kate probably has had this experience, I suppose, sometimes the statistical part of meta-analysis turns people off doing a systematic review, or the kind of potential statistical analyses that are implied in meta-analysis would turn people off. But I would say for a Cochrane review, there's huge support. For non-Cochrane reviews, there's huge support. And there's a package I'll show you called Review Manager, which really manages a lot of this analysis for you once you understand enough to say, yes, I think that's accurate. And this is what you would get as a result of those analyses. A meta-analysis would create this forest plot. Now, this isn't a great looking kind of tree in a forest, but the idea is the trunk is in the middle and these are the branches. And so each study is a line or a row. So it tells you how many people in the treatment group, 9 out of 47, had their ear infection, or they had no ear infection. In the control group, it was 10, or maybe these are ear infections. And then in all of the other groups, so you only enter the data that are here. You click on these studies, you bring them into the meta-analysis, and this forest plot is generated. RevMan, this package, will calculate the weight that study is going to be given based on the sample size and this kind of confidence interval. Where these arrows go off to the left or the right, it means really, that we're not sure at all about this kind of a study result. And in the end, we have this pooled effect at the bottom. So this kind of diamond shape, and if it crosses this line of no effect, it means it's not statistically favoring the treatment or the control, but there's no statistically significant difference here. Now, any of the master's students I've worked with on systematic reviewing have never gotten to the stage of doing a meta-analysis like this, because all of these studies have to have a lot in common in terms of the intervention they're testing, the comparison they're testing against, the outcome measurement, what scale they use for outcome measurement, whether it was on day 3 or day 50. So you don't often get to this kind of result in the end, even if you wanted to. But obviously I can come back to that, but I would say this is done in 5 minutes, but it is the interpretation of it that's important. So I suppose going back to this kind of planning of a systematic review, the top 3 are needed in a protocol. So Cochrane has a very kind of structured approach to, you register a title, then you register your protocol. They both get peer feedback, and then you publish your systematic review, and that also gets a lot of peer feedback. Sometimes you get 5 peer feedback sets of reviewers, which probably you don't really want, but you do get all of that from different perspectives. I suppose Cochrane has always had what they used to call the consumer input. It's always been really important that somebody from a patient group or the public, or as they used to call them, the consumers of healthcare, review the title, make sure somebody should be doing this review the protocol. Is there anything missing from the kind of patient public point of view? Is quality of life included enough? Is the kind of experience, the symptom relief, all of those things that, patients, it's certainly in the early days, we're saying, look, this isn't highlighted enough in such a review. So if you were registering a Cochrane protocol, but even if you weren't, I would say, it's a good idea to kind of follow these. And like we said about this being reproducible and, trying to lower your own risk of bias, having these set out in advance, then search for your studies, see which are included, actually extract data. Does that mean taking out some numbers? So the numbers we would have taken out to create that forest plot, or to generate that forest plot, was like the number of infections, the number in each group, looking at risk of bias in the studies from what we can tell from the reports, analyzing the results ourselves based on these data that are extracted, interpret results and draw conclusions, and then continue to update your review as the years go by. So I started on this, I think, 2007, and you're kind of given a review and you have to keep at it every couple of years to update it with new information, new studies. You've all probably heard of PICO, the acronym, participants or population, interventions, comparisons and outcomes. Sometimes there are no comparisons, so it's all interventions tested against all other interventions, or it could be a very specific new drug against the best performing existing drug. So like that, the review questions should follow the kind of questions that the people in those kind of who are carrying out those trials are asking. So that will all make sense based on your own area, your own question. Oftentimes as well, the S is at the end there, or the T for types of studies. And really, This should specify, I suppose you're starting to think about, am I only looking at randomized controlled trials? Am I looking at non-randomized studies? And there are really important implications for those. I suppose traditionally Cochrane reviews and systematic reviews were based on the RCTs, just randomized controlled trials, because a lot of the review and the risk of bias evaluation is based on the risk of bias brought about by problems with randomization. If randomization isn't done properly in a trial, it leads to all sorts of problems, and you're trying to judge that. So I've been on training courses where we spend 2 days looking at one domain of bias for like a cohort study, because it's really quite different. So I would say that people doing kind of systematic reviews of non-randomized studies need a lot of support in terms of how they'll go about those. But definitely those kinds of questions need to be asked, and those kind of reviews of non-randomized studies need to be done as well, need to be carried out. So therefore we need to keep progressing. So I would encourage you, maybe just to kind of think about this, have your own diagram or, your own table where you're thinking about what am I interested in, who are my participants. I think, this starts to, very quickly, you might say patients, and then you're thinking, okay, would that be males and females? Would it be any age group? Does it include children? And then what kind of conditions are you interested in that these patients might have? Would it be difficult if they had, multi-morbidity? Would it be practical if they do, because they usually would in practice? So all of these things start to inform your own, I suppose, in your own question. The PICO isn't the question, but it will inform the question. So you'll see this leading to your objective, leading to your question, leading to your search strategy. So for me here, my participants would be, women in early pregnancy up to 20 weeks gestation with nausea, vomiting, and retching. Sorry, I keep saying those words, not very pleasant, but obviously I'd need to kind of pin that all down there so that I'm not later on wondering, oh, here's a study with, women who are 22 weeks gestation. Let me include that study. I can't if I've said it will be 20 weeks gestation or 12 weeks or whatever else I might want to say. The intervention here can be really narrow, could be one specific, chemotherapeutic drug and very new thing, or it could be all interventions for my group. You mightn't have a comparison. As I said, your comparison could be just all interventions tested against anything else, including placebo. And the outcomes are really important. So here you start to think about, symptom relief, economic impact, quality of life, adverse events. If your study is within pregnancy, it might be adverse events. There might be, fetal outcomes, maternal outcomes. So you have to think about all of these in advance. Now, you don't usually, like, your outcome could be pain. And then you need to think, am I talking about chronic pain, acute pain? You start to think then about how will pain be measured in the studies in which I'm going to show some interest. So I would really, encourage you to really think about this table as much as you could if you were interested in any type of review. But there are different types of tables and different types of models for different types of reviews, because you might be more interested in a phenomenon than an intervention. So this could be phenomenon where you're looking at, it could be grief, it could be parenthood, it could be, whatever it is your phenomenon is, and then there's no comparison. It's, you'll follow the kind of design again. I mentioned that you would find your kind of PICO elements. You'd really be clear about those, and that would help you to inform your search strategy. Now, again, some of us, including myself, who I did a library and information studies degree in UCD many moons ago, but I still kind of panic when I'm set about doing a search that I will be able to say, I have found everything there is. But I think, Cochrane would always recommend you work with a librarian or an information specialist. A lot of the groups have library and information specialists. You could join, you could ask them, they could do the search for you. Some of them do, some of them give you the output of the research, of the search. But I suppose what this search, which is used in the Cochrane training, just kind of highlights, you might think, you know, oh, I'm interested in this issue, which we all are now again, if we can become airline passengers again, of compression stockings for preventing DVT in airline passengers. So, you know, if I was, you know, in a hurry, I might just say airline passengers and DVT and compression stockings in a Google search, but I wouldn't really find much. So what this is encouraging us to do is, these are the medical subject headings, you know, or the subject headings in a particular database. So this is Central, which is a register of all trials that Cochrane librarians and the whole machine of Cochrane is adding every day to this database of trials. So you can see there are already terms like aerospace, medicine, travel, aircraft, aviation, transportation. But then maybe we also want our own free terms, aviation, aviator, and these wildcards will add in airlines, aeroplanes, aircraft. So by the end of here, number 10 is going to bring these all together. So we now have about probably 20 or 25 words that all relate to travel on airplanes, because, you know, we kind of tease down a little bit. If we were in the P of the PICO, we'd be saying, well, do we really mean the business class people who have those lovely big beds that we all walk past in absolute envy, and they have their lovely things that they're not going to get? Well, presumably they're less likely to be, you know, in cramped conditions. So actually we need to clarify that it's economy, and, you know, that it's not the travel staff, it's the people sitting in the planes. So all this is going to show is that, and I'm making us all want to go on trips, but that all of these terms have gotten us to this place where we're interested in airline travel. Then we have a couple of terms for the bandages, stockings. Then we have the kind of the conditions that we're interested in related to DVT, and only at the very end we're combining those. So it's just really that maybe we need to change something up here, then we change it up here, but then we rerun the search, and in the end we're getting, you know, only all of this and all of this together. So searching is so important for systematic review, for scoping review, for every kind of review, but they are different. They're different kinds of searches. Scoping reviews will tell you, keep going until you're, you know, you've searched all the reference lists, you've looked online, you've done all these other things. Whereas the value, I suppose, of a systematic review is that you're looking normally, you know, for trials. So you're looking in here in somewhere like Central or some of the medical databases. I suppose you are interested in bias because, you know, studies are carried out differently. You know, should I believe these results? We can't go back in time and say, oh, look, those you know, those trialists were trying to, you know, prove that or trying to confirm that their intervention worked. So they put all the healthy people in one group and all the others in the control group. So we can't measure the actual presence of bias, but we're looking for risk of bias. So I'm not going to go into this, just to say that it's a really lovely thing to learn. It means that if you're eventually doing a trial again after you're doing your review, which is always a good thing to make up for the missing trials, you're assessing each kind of trial on a number of domains, whether it's a low risk bias, high risk, or unclear. So you're just reading what they've reported. Things like I mentioned earlier, randomization, you know, all of these are really important. Blinding, once the trial is underway, you know, have incomplete outcome data, have people disappeared out, we don't know the attrition from the trial hasn't been explained. You know, selective reporting has only the outcome data from day 15 and a half been reported, even though it was measured every day. So all of these are important, but it's just something that makes you much more aware afterwards of, you know, what goes on in trials, and you become a little bit of a conspiracy theorist. But again, you can see a good trial and a low risk of bias when it's carried out. And all of this has been updated. There's a risk of bias 2 tool in Cochrane. Again, I'm doing all that training myself because I'm interested in this. But so just going back to what I said, randomization is the kind of, you know, fundamental idea behind an RCT. So if it's going wrong, that, you know, you might decide later on, I'm going to exclude all the trials that had a high risk of allocation bias. So in the first two criteria there. Just a really quick sample of a Cochrane review that I developed, and I'm conscious of the time. You know, in the end, there were 27 trials, 4,000 women. We weren't really able to pool any of the studies. You know, there were several studies of ginger, but they were all, some were syrup, some were capsules, some were other things. In some of them, vitamin B6 was the active kind of intervention. In some, it was the control. So really difficult to kind of say anything at the end of it. And that's probably because we said all interventions. Very little reporting of adverse events, very little reporting on quality of life, and none on economic costs. So these are really important messages. Even if they weren't done in those trials, other trials should do them. That's what your risk of bias assessment looks like, the outcome. A kind of a traffic light system, so you can immediately tell, you know, well, there's a lot of green there, that's okay, but there seem to be problems with blinding, so people seem to know what arm of the study they were in. You know, it is a little bit frustrating that you end up saying there's little strong or consistent evidence for any intervention, but that's an okay conclusion as well, because some people would say, oh, I read a study on ginger and it's really helpful, and you're going, oh yeah, but put against all of these other ones, and some works, you know, some show it works, some show it doesn't. And it was published, and BBC picked it up, RTE, 4FM in Dublin, because it was about morning sickness, I would say. So I would say you can have quite a strong impact with this kind of review, if that's what you're interested in terms of the public kind of communication of research. It was part of the journal club, all of this kind of thing, because people are interested in morning sickness, not really that they're interested in a Cochrane review, which is fair enough. I mentioned this review manager. It's a standalone package. You do have to download on your computer unless you're doing a strict kind of Cochrane review, but it's a really nice package. This is what it looks like. It's just like a hyperlinked kind of structure at the side. You just type in like you would in a Word document. There's hyperlinks to articles, and that's where you enter your data. So like this forest plot on the right is generated. You can see there were 2 headaches out of 31 for Amore Coffea, that fake trial of coffee, and 10 out of 34 here. So again, this diamond here in the results isn't free of that line of no effect. So we wouldn't say decaf is more effective, or, you know, more effective at having fewer headaches than caffeine, although I'm not sure that's true. So, you know, if you were doing this kind of a review, but not through Cochrane, I would sometimes use these headings for our master's students. You know, so it looks different than a typical kind of dissertation where you have a big literature review, you have your own methodology about your primary data collection, then you have your results. So you kind of give the background first, why it's important to do the review, then a very clear methods section, and the results are where you are, you know, showing what you found on all of these previous studies. Now, I'm kind of, there's a couple of sample Cochrane reviews, but there will definitely be, you know, probably tens or hundreds in your own areas. Lots of supports, your review groups, so the pregnancy childbirth group, the pain and palliative care group, you know, they're organized kind of by clinical concerns. They're not always, you know, some are broader than others. There's a nursing care field I joined, and I sometimes do kind of summaries for those, and lots of training, lots of really interesting meetings always. All I have left really is just a couple of slides. I probably won't, I'll just even mention the kind of what's in them, and you can have a look later. We're currently doing a realist synthesis or a realist review, and this is much more, well, it's becoming a lot more popular, I would say, and it's a massive learning curve here for me, but it's kind of saying, rather than saying does something work or not, is it more effective A than B with your forest plot, it's saying how, why, when, and for whom, and under what circumstances does this work. So you're going back to, again, you're going to other people's research, and you're digging out kind of data to try see what's actually happening, under what circumstances, as recorded here, do you know, does this seem to lead to an outcome that you would want? So I've loved doing this on a project in Malawi at the moment on care groups. It's kind of a community volunteer kind of structure, and we publish our protocol. It's always good to publish your protocol, and we're just publishing our findings now. There's a scoping review, which is kind of mapping all the available evidence in your field. I mentioned we've 280 something articles in our baby friendly scoping review that's just come out. Again, we published the protocol just to tell people what we were setting about to do. It's trying to reduce again the bias of, oh, look, we found something really interesting. Let's change our topic. And there's really good resources there from Joanna Briggs. Again, a lot of our master's students are now doing scoping reviews. You know, what's here, what's the gap? Evidence and gap maps are really becoming popular as well with organizations like UNICEF, World Health Organization. So they're saying rather than even just spending a year doing a Cochrane review, let's try map out all the evidence that exists. And you set the kind of the axes. Here we have child level intervention, household level intervention, and this is about child labor, nutritional outcome, health outcome, but it doesn't really matter. It's just that you begin to plot, okay, there's one good study on school-based health and there's health outcomes, but all it helps you do is really see the gap. So, you know, the authors here have highlighted there's a gap here, merit-based scholarship. It doesn't seem to have been studied, scholarships and allowances. And these relate to the quality. So the red ones are kind of poor quality, green are better quality. So I would just say that Campbell Collaboration here is a kind of a sister organization to Cochrane, and they're really kind of pushing these ahead as well. And last but not least, because Kate is listening and it's her PhD student and Kate's work and with her colleagues, I would say that a lot of people are also interested in qualitative synthesis. So often we might think, oh, I wonder, will I do a primary study? You know, how have people experienced respite services? Who will I ask? Who will I invite? And then they do a little bit of a search and see, oh, actually there is research on that, but it hasn't really been brought together. So Emma, in this case, and Kate and colleagues did this kind of a synthesis, meaning you're creating something new relating to respite and dementia. An approach, a particular approach was employed. Again, it's a research design using other people's data, just as important to use data properly. And the link to the study is coming, so I won't focus on these, but again, just to really highlight that there are strict inclusion criteria. There's a strict kind of record of when studies were found and excluded and included. There's a very clear set of results, 23 papers, 20 independent samples, 5 key concepts, and really importantly, this is what I mean about creating something new. Here we have, you know, this model based on this analysis. We have a quality assessment of all the studies in order to be able to say, you know, rather than maybe doing one more study, which probably by itself wouldn't really help us to move ahead, it's really making the best use of all the studies that have been done. So don't, you know, feel that there's anything less systematic or less productive or important in terms of implications for any of those kind of reviews if they're done well. So I'm sorry that was as quick as I don't know what, and I don't know if you took anything in, but hopefully you did, and we can definitely have a chat afterwards. I don't know if there are any burning questions, but I know we probably need a cup of tea, so that's always good as well.